Okay, now we're ready to discuss what do the test results mean. And so the interpretation of the test is obviously the main reason why we do it. If a child reads the vertical array of letters very slowly and also reads the horizontal array of letters very slowly, and if the ratio of those two is basically 1 to 1, then we can say that that child does not have a tracking problem or eye movement problem, but rather a language processing problem, or what I've already referred to as a rapid automated naming problem. That's one type of result on the test. To repeat, the child is slowly, for their age, norms, slowly reading the digits out loud, whether they are arranged vertically or horizontally. That is not a tracking problem. It's a language problem. Our second possibility is the child reads the language array, the language plates normally, at normal speeds, but when confronted with the horizontal array, and therefore the tracking technique is underway, they read slower. That is a pure tracking problem. Emphasis on the pure, because we know their language system is normal because we tested it. So they can say the digits out loud correctly and in the time they should as for their age, but they cannot do that when confronted with the random horizontal array. So that's a second type of problem. Normal language skill, abnormal tracking skill equals tracking problem. Now we have a third type to discuss, and that is a child who has a slow vertical response, but an even slower horizontal response. Therefore, we have a language problem diagnosed by the rapid automated naming failure, and a tracking problem proven by the fact that canceling out the rapid automated naming error, which we have done by plates A and B, we still have a lower than average or expected tracking score. And so that's a third possible child that you will examine. It's obvious too that you can have some children who will score normally, completely normally on both aspects of the test. I didn't discuss those because they have neither problem, obviously. So to review, the first problem you can have is a child that has a language problem and not a tracking problem. The second problem that you can have is a child that has a no language problem and a pure tracking problem. And the third problem you can confront is a child that has both. And the beauty of this test is that it actually gives you all of this data within about a 2 or 3 minute time administration. Okay, the final leg of our journey here is how to score and interpret the test so that you know what to do with the child once it's been done. So this test has been given, and incidentally, reliability and validity studies were carefully constructed, and the test shows excellent, above 85 to 90 on all reliability and validity tests that were given. So we know the test is valid, we know that it's actually checking for what we think it should be checking for, and we also know that it's repeatable or reliable. So those two things have been well studied. You will receive, incidentally, a manual with the test once you get ready to get moving with it, but this will give you a more specific instruction set. Okay, so here in my hand I have the grade score for ages 6.0 to 13 years 11 months. You'll notice on the left the age scales, which obviously can be correlated with grade scales. And then you'll see means and standard deviations as you go across the card for each grade level. First you'll see a vertical mean, then you'll see a standard deviation, and then you'll see a horizontal mean, and then I think there's a ratio mean on the far right side. I won't tell people who know more about statistics how to interpret statistics. Just a quick reminder, a failure on the test is considered one standard deviation or more below the mean for age. So the criteria that we normally use, criterion, is one standard deviation below the mean for age. Okay. Now the second part of this I want to show you, because it's quite a bit more specific is, and I just picked the table for 7-year-olds. Here you can see the actual, you can actually get the percentile ranks right off the raw score. So you can look at the raw scores in one column, and you can go directly across to percentile ranks in the column next to it. And you can also see at the top of the test that this will tell the the number of kids in the clinical studies originally that was done in each grade. So my memory is that we did about 1,000 kids in the initial study, and so you'll see if you divide those by the 7 or 8 grades that we're talking about, there's going to be 75 to 80, maybe 85 kids per grade. But certainly enough to get a decent set of numbers and statistics. Our final part of our job is to now give you some feedback about what is helpful and useful to you to know who should be referred for interpretation of these tests. So as I mentioned in the last block, the simplest way to decide if you have a bona fide tracking problem, once you've learned the interpretation methods I've taught you, is do you have a child scoring 1 standard deviation or further below on the grade norms for their age for the tracking performance. If you do, it merits a referral. Now this part of what I have to tell you, I will stay brief, but I want you to know there's a lot of depth to this part of the field. Children who have, and adults who have tracking problems nearly always have other visual deficits that are either contributory or comorbid with their tracking problem. Quick example, many children have convergence disorders or eye-teaming disorders, which create a set of static on their system, which then leads to a poor ability to track or keep sequence as they read across the page. We are not asking you to diagnose those children. That's our job as eye doctors. What we are asking for your help in finding these kids, and this test is a very powerful tool in your toolbox to do that. So I would like to recommend that if you have a child who you've administered the test to, and they are 1 standard deviation below the mean, that's a very simple and straightforward black and white cutoff system that we could begin using with you to refer the children into us and to have Dr. Ramsdahl and myself help you take care of those kids and help them so their visual skills can be made normalized. One other quick comment, since I know you deal with a lot of behavioral issues in your clinics, many children who have other behavioral disorders, psychiatric and psychological disorders, including ADD with or without hyperactivity, will have manifest oculomotor or eye movement skill problems. These may run together, there may be some relationship between them, but we know from pretty good studies and clinical work that it's rare that medication or behavioral intervention on these children for their behavior will make their oculomotor skills or their tracking skills normalize. You need the help of professionals that do that work in addition to the very good work that you do on behavior issues for these kids. So we'd like to partner with you to help the kids do better in school and in life, and we can do that by having you help us to find kids who have difficulty with their eye movements. Thank you.